Good afternoon, everyone. Thank you so much. My name is Aditi DeBroy, and it's my immense pleasure to welcome you today to our panel on Doubly Informed Evidence and Best Practices for MSI-H and MMR testing in metastatic colorectal cancer. So this is a quick disclaimer. This is not a CME event. Few housekeeping rules before we start. Please keep your phones on silent, but please keep them handy because we have Slido questions built in throughout the panel discussion, and we would love for you to be responding to them and making it interactive session. So it is my true honor and privilege to introduce our multidisciplinary panel here today. Our first panelist is Dr. Michelle Schiller. Dr. Schiller is a board-certified Mayo-trained molecular pathologist with PATH Group, where she is the medical director of Genomic and Molecular Pathology Services. Dr. Schiller is also the medical director of cancer genetics at the Baylor Sammons Cancer Center. Next, we are joined with Dr. Jonathan Nowak, who is a molecular and gastrointestinal pathologist at Brigham and Women's Hospital and the Dana-Farber Cancer Institute. He is also an assistant professor of pathology at Harvard Medical School. To round up our panel, we have Dr. Leon Pappas, who is a medical oncologist at the Mass Gen Hospital and instructor in medicine at Harvard Medical School. He specializes in the treatment of gastrointestinal cancers as well as in the development therapeutics. Here is a brief snapshot of the agenda. Next, Dr. Schiller will be setting up the stage for the panel with a brief presentation, which will be followed by the panel discussion. Then we will be closing up the session. So please hold up your questions till end of the panel discussion. If we end up not having time, the panelists will be here after the session. So if you want to hang around and ask questions after, but we are hoping to spend a few minutes at the end of the panel discussions with questions. This is a QR code. I would highly encourage everyone to go ahead and please scan this code. These will be used for the Slido questions. So once you scan it, it will have a pop-up screen. You will be guided through a few questions as listed here. And after that, you'll be all set for the rest of the Slido questions coming up. So with that, I will hand the floor over to Dr. Schiller for the presentation.
Thank you so much, Aditi. Hello, everyone. Thank you so much for coming today. I also want to thank BMS for sponsoring this event, and thank you for spending some time with us during lunch today. As was already mentioned, today we're going to talk about exploring evidence-based treatment outcomes and specifically really focusing on the role of microsatellite instability and mismatch repair protein testing in metastatic colorectal cancer. This first slide is an opportunity to have a level set as to the relevant biomarkers at this time in colorectal cancer, and it is taken from the NCCN guidelines. My true hope is that each of you utilize the NCCN guidelines as a source of reference because they do update on a regular basis as different biomarkers become relevant in the treatment considerations for our patients. For our time here today, we're mostly going to focus on the middle-ish of that table, focusing on microsatellite instability testing and mismatch repair protein testing. Importantly, according to a U.S. cohort study of biomarker testing in patients with metastatic colorectal cancer, there are a number of factors that impacted reduced likelihood for microsatellite instability and KRAS testing of which has been around for a long time as a recommendation in colorectal cancer. And those factors include older age, community setting treatment, which is where most oncology is treated in this country, lower educational level, and being in the location of Mississippi and Kentucky, according to this data. Focusing a little bit more now on microsatellite instability and mismatch repair protein testing. These two biomarkers are critical for identifying patients for two important things. First and foremost, of course, Lynch syndrome, which is how we really first came to understand these biomarkers, but also for selection for immunotherapy. So it also drives the treatment selection for these patients. And importantly and individually, microsatellite instability testing is crucial to identify these patients who might be eligible for appropriate immune-based therapies, and in similar vein, mismatch repair protein testing. But I do want to reiterate that when we find a patient who has microsatellite instability high and or loss of mismatch repair protein function, they have simultaneously also screened positive to be at risk for Lynch syndrome, and no workup for this would be complete until that answer has also, or that question has also been answered. So when a patient has one of these biomarkers that's positive, that does identify them for immunotherapy, they also need to have a completion of their workup with respect to the Lynch syndrome question. Approximately 15% of all patients with colorectal cancer and 4 to 5% of patients with metastatic disease have microsatellite instability high or mismatch repair protein loss of function. Now, the testing, seems very straightforward sometimes when we talk about it. First, we're going to talk about some of the implications. Accurate testing is essential for optimal patient management and treatment planning in this setting, and we're going to focus on that testing in subsequent slides. But clinically, it helps to inform immune-based therapy and other things. It also informs surgical management for the patient and also the direction for genetic counseling. It also has a prognostic role, as patients who have microsatellite instability or mismatch repair protein loss of function do have a better prognosis. When we look at the guidelines, and I already referenced with respect to the NCCN guidelines with recommendation of testing, we also have additional guideline recommendations to consider. ASCO, AMP, the CAP, and the ASCP all recommend mismatch repair protein testing and microsatellite instability testing in patients with colorectal cancer, and this is a strong recommendation. ESMO, so our European colleagues, further recommend that, and they specifically state multimodality testing. And then lastly, NCCN, as we've already said, does recommend both mismatch repair protein and microsatellite instability testing at diagnosis in all newly diagnosed colorectal cancer patients. So in summary, all of these patients who have a diagnosis should see this testing. However, the reality is that despite guidelines universally recommending this testing, the testing uptake still does not represent those recommendations. While 84% of healthcare practitioners are aware of the guidelines, only 70% of patients are actually seeing the testing. When you look at that even further, the greatest difference is seen between the actual practice setting where the patient is cared for. In the academic setting, that is where you see the highest uptake for both microsatellite instability testing and mismatch repair protein testing. However, in the community-based setting, which is where most patients in the United States are treated for their cancer, only 3% of non-academic institutions performed both immunohistochemistry and PCR-based testing. And that study was specific to PCR. Of course, I and many of you are likely aware that you can assess for microsatellite status utilizing NGS. So looking at this particular slide, and will be elaborated throughout our discussion this afternoon, is that different modalities of testing have strengths and weaknesses, if you will. So we're going to focus in on that a little bit for each of the common modalities utilized to look at these biomarkers. So first and foremost, looking at PCR, that's been the mainstay. It's the way we've assessed this for many years. It has very high sensitivity and specificity in colorectal cancer, particularly when we have a tumor cell content of greater than or equal to 30%. We're also very familiar with it, and we've done this a long time. That's really how a lot of the original microsatellite instability testing was performed. However, a limitation of PCR-based testing is that slight movements in the microsatellite marker length may result in a false negative result in some solid tumors. So again, it's important to understand every different way we test is going to have strengths and limitations. Moving on to immunohistochemistry, it directly detects the presence or absence of mismatch repair protein expression with a lower required tumor cell content than would be PCR or a genomic-based assay like NGS. You need greater than or equal to 50 cells or 1% tumor cell content. However, with immunohistochemistry, and some of you may have actually dealt with some interesting results or challenging results in your hands, It is true that sometimes a mutation may produce a non-functional protein that is still detectable by IHC, but yet might have a quote-unquote discordant result when you move on to PCR-based testing. Again, another reason to have multimodality testing. And then lastly, rounding out one of the ways we can detect microsatellite status is looking at utilizing NGS. And you can detect both microsatellite status with NGS, and oftentimes, based on the coverage of the test, you can also determine the genetic status of the different genes that create the proteins in the mismatch repair protein pathway. And it can sometimes help to detect some cases that might be missed by PCR or by your IHC assay. However, one of the issues or concerns with next-generation sequencing is a lack of standardization amongst all the different assays that are utilized throughout the country and a slower turnaround time, to name a few of them to highlight. There is high concordance between these testing modalities, and they're highlighted on the left-hand side of the screen there for you. Important considerations for this are looking at the fact that sometimes there's insufficient tumor sample due to a low tumor burden and tumor DNA degradation, which can occur over time if you have an older specimen. These things can lead to false negative results in PCR-based MSI testing. Additionally, sometimes limited access to people who utilize these tests regularly, so academic centers or wherever you have a GI specialist, if you don't have access to that and you have challenging cases, these are some considerations to think about with the testing. Not that it always would require that, but for those challenging cases, it's nice to have significant experience to lean on or subspecialization. And then finally, there's a high concordance between clinically validated assays, but this may or may not extend to laboratory developed tests depending on how they have been developed. Ultimately though, NGS, PCR, and immunohistochemistry are reliable methods for the detection of microsatellite instability high or dMMR detection. These methods are proficient for establishing the status of mismatch repair protein loss of function or microsatellite stable or unstable, and there are caveats around their limitations as we've already discussed. And then of course, other things to think about are looking at what are we going to do when we have some results that may not meet what we expect. So this slide is kind of intended to convey some of the things that we know happen out there. So first and foremost, what is a discordant result? A discordant result occurs when mismatch repair protein expression and a microsatellite test result produce inconsistent results. So perhaps you have intact expression of mismatch repair protein by immunohistochemistry, and then you get a result of microsatellite unstable. So what do we do in this circumstance? What should be done? It's recommended to interpret any evidence of mismatch repair protein deficiency by immunohistochemistry or MSI, by NGS, or PCR as a positive result. At least for the therapeutic use of decision-making, you only need to have either one or the other. However, I also recommend when you see this to go ahead and take a second look back at that case, and we'll talk more about this momentarily. With indeterminate results, so what is an indeterminate result? Well, that is when we see tumor cell staining less intense than that internal control, or the expression is retained in less than 10% of the tumor cells. So what should we do? Well, one and very early thing I refer to is phoning a friend. And I let my colleague look, hey, what do you think about this result? So trying to establish a consensus amongst my colleagues, or also looking at orthogonal methods to really try to understand more what's going on. And then lastly, subclonal loss. Subclonal loss, we know cancer is heterogeneous, right? And when we see subclonal loss, that is just evidence of that, the presence of intratumoral heterogeneity that we are seeing underneath the scope. So one recommendation, just like when we try to optimize for tumor cell content in next generation sequencing or in interpreting HER2 as another biomarker, microdissecting that area that has loss to see if that is microsatellite unstable in that area. So looking at tissue quality, because this is also critical for successful testing actually of any type, and also here focusing on mismatch repair protein and microsatellite instability. It is also important to realize that like other immune-based biomarkers in for example, tumor mutation burden, microsatellite status can be induced, particularly if a patient has been heavily pretreated. So whether or not to repeat it would be something of consideration, not in the context of Lynch syndrome at that point, but did the patient's tumor acquire microsatellite instability over time? And then also, from analytic factors, I do think we're moving to a space where we need to know the formalin fixation time on every single specimen, and where possible that cold ischemic time, because it impacts our ability to get successful results down the line. And some of the times when that's not captured on a specimen, we're left scratching our heads trying to determine the reason why. Another recommendation is to use standardized protocols for antigen retrieval, incubation, and detection. So standardized protocols helps you to understand if that was deviated from, that might be one of the sources as to some of the interpretive considerations with an assay. So in summary, microsatellite status in MSI-H and mismatch repair protein status and lack thereof are known critical biomarkers to screen, again, not only for the presence or absence of Lynch syndrome, and please always complete that workup when someone screens positive, but also to identify patients with metastatic colorectal cancer who may be appropriate for immunotherapy. And so it guides treatment selection, and that's very important. Despite guideline recommendations, we're still not hitting the 100% benchmark on testing. And concordance between the different approaches, next generation sequencing, immunohistochemistry, and PCR are high, but awareness of the method limitations is important to keep in mind to ensure accurate testing and reporting of results. Lastly, it's important to address physician barriers to testing and improve communication. I cannot overemphasize the value and importance of a multidisciplinary team that is well integrated, as well as education on the benefits of testing, which may help to enhance the uptake of testing in this setting. So now I'm going to go ahead and turn it over. I believe we're going to move to the panel discussion now. Thank you.
Thank you so much, Dr. Schiller, for that engaging and informative presentation. Maybe we can start off by discussing the current testing practices at your institutions, and when does the testing happen in the diagnostic pathway, which biomarkers you test for, and how do you prioritize them in CRC? Maybe we can start with Dr. Nowak.
Great, thank you, Aditi. So I would first start by saying there's multiple ways to do this testing. There's not necessarily one best right approach. At our institution, and I think this is probably the most common approach overall, we start with MMR-HC on all newly diagnosed invasive colon cancers. And this is something that is initiated by the pathologist as soon as they've made that diagnosis. And once we have the IHC results back, there are 4 main outcomes that can happen, assuming that IHC is interpretable. And age also comes into play for us here. We can take the simplest scenario first. If you're 50 or older and MMR-HC is intact, we generally stop testing there. There's a very low chance that there's anything unusual going on that would give you intact MMR-HC and actually an MSI-H status. If you are less than 50, we will then reflex order MSI testing by PCR, because we know that for the younger patients with an increased chance of having Lynch syndrome, there's a greater probability of having expression of a functionally defective but still expression retained protein. And so we'll reflex to MSI by PCR. And then that leaves us the 2 main patterns of MMR-IHC protein losses. Most people in the audience probably know loss of MLH1 PMS2 is far and away the most common pattern. These are typically patients that have sporadic MMR deficiency. And so for all of that IHC pattern, we will reflexively order MLH1 promoter methylation testing. And for all of the remaining patterns, we will then report those out with a note. And I typically email the ordering provider as well to indicate that that pattern is possibly suggestive of Lynch syndrome, or at the very least, the patient needs somatic next generation sequencing to determine whether they have 2 somatic and activating alterations in their tumor. So that is our, in a nutshell, kind of triaging workflow for MMR. I would say it's really pathology driven, which I think is helpful for getting that testing done for all patients. Whenever we receive consult material from the outside, if IHC hasn't been done, we will request unstained slides or a block and then do that and add that to the report. Beyond MMR testing, we typically do HER2 or ERBB2 IHC for metastatic cases. And beyond that, for all of the other biomarkers that we know are of interest, especially for metastatic colon cancer, including TMB, BRAF, also HER2, the rearrangements like RET and NTRK, we use next generation sequencing as our first line to detect all of those.
Perfect. No, thank you so much for sharing the comprehensive biomarker testing approach at your center. Dr. Pappas, we would love to hear from you as a medical oncologist how you approach biomarker testing in CRC.
Of course. Thanks so much, Aditi. Yes, so I think the biomarker space is really evolving in CRC. Finally, we're having some very actionable biomarkers, so it's a very exciting space overall. So as a medical oncologist, really, I see patients come in 3 streams with CRC. One is the newly diagnosed metastatic patient, in which the medical oncologist is usually involved early, sort of helping guide which sites have to be biopsied, and then working very closely with pathology to determine what biomarker testing we should order and how to interpret that. The second stream is the patient who has a new diagnosis of localized disease or locally advanced disease, in which case usually I see the patient after gastroenterology has already done the colonoscopy and performed the biopsy, and then pathology has already already done the MMR testing at least, if not PCR as well. And then the third stream is outside consults from other institutions, in which usually testing is available. So the pathology is going to be available, and then we're going to have at least the MMR testing as well, if not as well PCR or next generation sequencing. So the testing that I look for and the relevant biomarkers differ in terms of whether it's metastatic disease and what line of metastatic disease and whether it's localized disease. So for all colorectal cancer, sort of the number one biomarker that I look at is MMR IHC testing and MSI by PCR. That's a number one biomarker. And then for metastatic disease, certainly look at HER2 because there's a clear indication also for the second line beyond setting. And then after that, for all metastatic patients, I certainly want to get next generation sequencing testing. Usually I get it upfront on diagnosis, but it's okay to wait until the second line as well because most of the biomarkers are actionable in the second line and beyond setting. Though the landscape, as I mentioned, is rapidly changing. So already for BRAF V600E, we have an indication in the front line. So I think getting next generation sequencing in the front line is very important. And that can give also information on MSI as well. So typically when I see a newly diagnosed metastatic patient, either through a referral from another institution or in our institution, we get the MMR testing and then we get next generation sequencing. I usually favor to get it both from tissue and from blood because sometimes there can be discordance, specifically in the biomarkers between blood and tissue. So that's usually what I favor. And more we're also seeing a push to do next generation sequencing in the earlier lines of therapy. I think there's some great work that Dr. Nowak has been working on as well with the PIK3CA mutations and them being relevant for NSAID use in the adjuvant setting. So I think slowly we're going to be seeing a push also for next generation sequencing in the earlier lines as well.
No, thank you so much. Really appreciate that perspective. We will be moving on to a few audience polling questions. So hopefully everybody got a chance to scan the QR code. I see that we already started getting responses for the first question. So what are the current MSI and MMR testing practices in metastatic CRC at your institution? We see that testing at initial CRC diagnosis pretty much trumps, which is not surprising, I guess. So we can move on to the next question. What is the testing methodology for MSI and MMR for metastatic CRC in your institution? The options are PCR, IHC, both PCR and IHC, and all of the above. Thank you so much. Again, I think this is something that we expected as well in terms of the IHC, but it's interesting to see that we don't see any, so we do see all of the above in 12% or so, so that includes the NGS. Moving on to the next question. What biomarkers are tested at the time of initial CRC diagnosis at your institution? Please rank from most to least prioritized options. So the biomarkers are BRAF, HER2, MSI, MMR, NTRK, POLE, RAS, RET, or no testing performed. Like there's a fight between BRAF and HER2 happening, but I'm happy to see that the MMR is on top right there. So it seems like the common biomarker that is being tested. Moving on to the next question, let's delve a little bit deeper into the significance of the MSI test results. Dr. Pappas, being the medical oncologist, if you could, share with us some of the clinical implications of a dMMR or MSI high result, it would really, bring that round-up perspective to the audience.
Yes, so certainly those results are really important and practice changing for the medical oncologist. So when we do get a dMMR or MSI high result, then sort of the standard first-line therapy for metastatic colorectal cancer is immune checkpoint blockade inhibitor therapy, either as monotherapy or as doublet. Recently, there's sort of some very encouraging results for doublet immune checkpoint blockade therapy in that setting. And what we have seen both from the singlet as well as the doublet data is almost 5 times or even greater increase in progression-free survival between use of chemotherapy upfront in the frontline setting versus immune checkpoint blockade inhibitor therapy. And this is a striking difference in the overall response rate as well. So this can certainly have significant clinical implications for the treatment of patients. I would say in terms of actionable biomarkers for colorectal cancer, that's how I think in terms of the biomarkers that, in terms of the testing they order for my patients, MMR testing and MSI high testing is sort of the most actionable biomarker, the most important biomarker. And if we do get an MSI high result on the NGS testing, for example, along with other actionable biomarkers like a BRAF, V600E mutation, or KRAS mutation, at least for current standard of care, the MSI high result trumps all others in terms of treatment. So we would give immune checkpoint blockade inhibitor therapy first, and then in the second line, consider other potentially targeted therapies or chemotherapy. So certainly very important for clinical practice. I think it's also important to work very closely with pathology to look at quantification, for example, of results on the MSI testing and sort of look at other nuances that may help inform specific patient scenarios. I think having that result is a key one for us.
No, thank you so much. I mean, clearly, the MSI results have a direct impact on the clinical decision making. But I know Dr. Schiller presented the slide, and we saw like there's still like 70% or so, which is pretty good. But we still have 30% or so labs not testing. If Dr. Schiller, maybe we can start with you in terms of what bad challenges or barriers do you think might prevent a lab from including MSI in their biomarker testing workflow?
Yeah, so I think a couple of things. So first and foremost, remember that that's 70%, but then when we looked at the subsequent slide, there's a significant drop-off in the community-based setting, and most patients are treated in the community. So that tells me that in the community-based settings, the testing's not being performed. Now, I think that largely might be due to a lack of perceived access to the therapy, or potentially also whether or not a patient would be able to get the therapy were they identified. I do also think that sometimes, because in the community-based setting, it's harder to phone a friend. You don't necessarily maybe have a GI expert on site to turn to for discordant results. I wonder if that sometimes might be what causes people to lend pause and not want to implement that testing locally. So I think that hopefully over time there is proficiency testing out there, and opportunities like that and other ways to share interesting cases would be a tremendous opportunity to help close some of those gaps. But Dr. Nowak, do you have additional commentary?
Yeah, I think, really one of the main things I would just add is that, as you pointed out in your presentation, we've had an indication since 2017 to be doing MMR testing for therapeutic purposes, but we've known now for 2 decades that there is also a very good rationale for doing universal MMR screening for all colon cancer patients to identify Lynch syndrome. So this is something that, from a kind of rationale is very well established now. This is not new. This is really something that we've known that we should do for quite some time. And so it is worthwhile thinking about why we still end up missing a significant portion of patients. I think, just looking at the polling question here on the screen, it really seems that, kind of far and away, it's an issue of tissue inadequacy as opposed to necessarily having the resources to do the testing, which I think we would all recognize, at least for IHC, as something that is pretty broadly available, and as well as reimbursement issues, which are probably a relatively more minor concern. It's hard to get around the inadequate tissue issue if you need foreign stain slides and you need to be sure that there's adequate cancer on each of those. But I think that is a very worthwhile point to keep in mind, especially as we move towards the need for more upfront biomarker testing for patients, as Dr. Pappas pointed out to us.
Thank you so much. Yes, the question was what challenges do you face when implementing MSI and MMR and CRC testing? So clearly inadequate tissue, as Dr. Novak pointed out, seems to be. Yes, please go ahead, Dr. Pappas.
And maybe to add a point there, I would say I would urge all pathologists to feel empowered to reach out to the medical oncologist that they're working with for any of these issues. So if there's a reimbursement issue, for example, and you'd like the medical oncologist to send some literature and to sort of try to advocate for the patient to get that test reimbursed, I would certainly encourage pathologists to do that. If there's inadequate tissue issues as well, reach out to the medical oncologist, see if there's another site that could be sampled. The way I approach this is teamwork, and I think with good teamwork, we can get good patient care.
Thank you. Thank you so much. So moving on to the next question, and shifting our focus a little bit to the reporting process. So how does the report represent the status of a patient when either IHC, PCR, or NGS is utilized to test the MSI status? What have you implemented at your institution to overcome any testing challenges? Dr. Novak?
Yeah, thank you. So as we spoke about, there's multiple different types of assays that you could use to determine MMR status, and at least at our institution, we report those differently. So MMR-IHC is reported usually as an addendum alongside the main surgical pathology report, and we're typically binarizing that into intact expression or any of several different patterns of deficient expression with then kind of appropriate follow-up information based on the specific pattern we see. For MSI testing by PCR as well as NGS, both of those results come from our molecular diagnostics laboratory. That's a separate workflow than surgical pathology, so those are separate reports. Typically, they're coming out after we've already done MMR-IHC, and I think it's always incumbent upon you, if you're signing out one of those cases, to put the prior information in context. So our MSI testing by PCR reports will also reference the MMR-IHC, and will correlate the IHC results with what we've seen by PCR. We do something very similar for NGS, where almost always there's prior data. NGS is usually the last thing that's being done. And if all of that data is concordant, I usually, at least for my personal reporting practice, don't make a big deal about it, but certainly really chase anything that ends up being discordant. I think this is also maybe a good time to mention that one of the challenges of detecting MMR deficiency by NGS is that really all of the algorithms that are out there, when you look under the hood, are measuring a continuous variable, which is some measure of number of unstable microsatellites over total microsatellites, or number of mutations that fit in MMR mutational signature versus all mutations. And so there's a challenge of having to convert that continuous variable into a binarized output, which is usually proficient or deficient, and sometimes with an indeterminate category as well. I think any lab who validates NGS to detect MMR deficiency typically uses MMR-IHC and MSI testing by PCR as orthogonal gold standards to figure out where best to set your cut points. But it's important to recognize that those are cut points. They're not absolutely perfect, and you will still have a low rate of false positives and false negatives.
Thank you so much for sharing that. And I know Dr. Schiller also pointed out for NGS testing specifically, there is a lack of standardization in terms of reporting. So appreciate you sharing the best practices. Dr. Schiller, we would love to hear from you as well.
Yeah, so much of what we do follows very similar to what Dr. Nowak does. And I was just going to also mention another route that sometimes happens is maybe a specimen sent only for microsatellite testing, and that's a common way we'll get an order. And so then my next question is, was MMR done? And this would be like in more of a reference laboratory setting. So I either can find out internally if it's a case from within the network of pathologists, or sometimes I need to track down the client. And if it wasn't performed, then I do perform it in-house. But if it was performed, I acquire those results. And the reason why is because when they do that, they have the option to check reflex or not to BRAF if we have MLH1 PMS2 loss. So a lot of the times they will ask us to do that. And I want to just mention that in addition to therapeutic status, BRAF has an important role for prognostics as well. And so there's a good case to run BRAF testing even in the early stage at the time of diagnosis. Nonetheless, I'm now pairing the result from the PCR with the MMR, and if I'm doing just standalone BRAF testing and it's positive, I'm done, but if I know there was MLH1 PMS2 loss, then I still need to go ahead and make sure that that reflex to MLH1 occurs. And also follow up with that. And then at some point, if the patient should end up then also getting next generation sequencing testing, also draw it together. But with each iteration of additional data, you continue to draw it together. It may seem somewhat redundant, but you just have to think about what if that one report got lost and separated from everything else. You have all the information relevant to that point in time in one place so that it can be the most helpful to our clinical colleagues.
Thank you so much. Yes, Dr. Pappas, please go ahead.
Yeah, I would say having a lot of information, having all the information in one place is very, very helpful, because then that helps us frame the case in context. So we see the clinical picture, and sometimes we have challenging cases where we are on the fence for deciding between immune checkpoint blockade therapy and chemotherapy or targeted therapy, and sort of having all that information can be really helpful in those cases. And sometimes we may decide to rebiopsy, for example, get additional information that can really help sort of our decision making one way or the other. So definitely want to echo those points.
No, thank you so much. Yes, and we do see that 40% of the poll audience did mention that they use an alternative testing method to confirm the result. But we do see that 10% reports out the discordance. So appreciate you, Dr. Pappas, also tying in the impact of testing and on specifically the clinical treatment decision and on the impact on the patient outcome. So appreciate that perspective. So you've highlighted efforts to overcome testing challenges. To explore further, what parameters that you could potentially lead to an uncertain result? Dr. Novak, do you want to explain a little bit further on that?
Yeah, so I think that those parameters, are really dependent upon the assay that you're speaking about, but we can start really and focus on MMR-IHC. I think for me, there are three essential elements that you need in order to interpret an MMR-IHC result. One is that for each of your 4 stains, and hopefully you're doing 4, you have expression in internal positive control cells. If you don't have that, you're done. You can't really go any further. The second, obviously, you need invasive cancer on all of your slides. And that sounds trivial, but I think as anyone here who has looked at a biopsy of the colorectal knows, oftentimes of the tissue fragments you have, only 1 or 2 may contain invasive cancer. There's oftentimes a lot of background adenoma. And so you do need to be sure that the cancer itself is present on all of those IHC slides. And then the third point that I would suggest is that if you encounter any unusual or sort of implausible IHC pattern, that should also give you pause. If you have loss of MLH1 but not PMS2, that is biologically pretty implausible and probably merits some repeat testing before reporting that out. So I would say, FFPE MMR-IHC is in general not incredibly challenging to do, but you do need to be comfortable with it. And I think it's also important to see, kind of like everything in surgical pathology, a certain volume of those cases so that you stay fresh with the interpretation and you do feel comfortable when they come across your desk.
Thank you so much. Dr. Schiller, would you like to expand on it as well?
Sure, absolutely. So also, whenever we have a result, it may be unexpected. And I do want to drive home that isolated loss of MLH1 is a non-entity and always warrants some additional look back as to what may have been happening at the interpretive level. But the very first thing that we do when we have a disagreement between our IHC interpretation and microsatellite testing is have this. So we do it digitally so we can look digitally at the case, or if you're still on glass slides, pull those slides. And then it's my recommendation to have someone other than the person who initially interpreted it review the case, just for a fresh set of eyes so that you don't have your own internal bias to want to try to agree with yourself. And then have a discussion and establish consensus around it. As Dr. Nowak also said, sometimes we don't have very much invasive cancer. And so it may be important to realize, did you lose the cancer in the process? What is it that you're actually interpreting? And be sure about what it is that actually went through the testing pipeline. Sometimes that ends up where you do have real MMR IHC loss, but then by the time the tissue got sent for PCR, if that's the second set of slides or deeper in the cuts, you may have lost the tumor. So that's another way in which you can see some discordant results.
Thank you so much. Yes, I think we did touched upon the when there is like patient referral, they're coming back, the tissue has had a journey, and there might be some sample quality issue as well. So just doing the due diligence to overcome the uncertain and confirm the result.
I would just add, in the interest of completeness, talking about the other assays, tumor content is really critical for NGS and MSI by PCR. We're fortunate that IHC is really, pretty sensitive down to very low tumor contents. So you have an assay where a particular strength is kind of a relative weakness of another approach. But that is oftentimes the biggest way that you can go wrong with the molecular testing, especially MSI by PCR. Probably really the least sensitive of the molecular assays as compared to NGS based on tumor content.
No, thank you for that addition. So from the MSI low implications, the uncertain results undoubtedly present unique clinical scenarios. So moving forward, how does a clinician utilize MSI low results to inform their clinical decision? Dr. Pappas, we would love to hear from you.
Of course. Yes, so we think of it clinically as medical oncologists, very similar to what Dr. Nowak was describing before, sort of the division between MSI high status or MSS, really. So for MSI high or for DMMR disease, again, standard of care would be immune checkpoint blockade inhibitor therapy in first-line metastatic disease, whereas for MSS, you would go to chemotherapy. However, we do get a lot of these, or increasingly more so as we're doing more NGS testing, you're getting these like MSI low or indeterminate tests. And the question is, what do we do clinically about them? Well, currently, we want to, for two principles, I would say. One, we want to have as much data as possible. So you want to take the case in context. So you want to have your NGS data, you want to look at the clinical picture, you want to look at your IHC testing, you want to look at your PCR testing and see exactly which loci were affected, exactly as was discussed previously, to understand what the exact clinical scenario is. Now, in the case, for example, where you have the MMR testing being preserved and you have an MSI low or indeterminate result by NGS testing, well, in those cases, we'd probably go to chemotherapy. But if there's something different, if we do see DMMR on the IHC and we do have an MSI low case with low volume that could potentially consider immune checkpoint blockade inhibitor therapy, that could be something that could be entertained. Again, immune checkpoint blockade inhibitor therapy in the MSI low setting is still investigational. It wouldn't be part of standard of care. But I think having all the data in front of you is very important as a medical oncologist to be able to make that decision, that call, usually as part of a team, multidisciplinary team. And second, I want to emphasize sort of that role of the team that I've been mentioning before. Always in these cases, I always work closely with my the pathologist that I've been working with on that case, and with medical geneticists as well if needed, just to understand what the best sort of avenue is. Other variables that I take into consideration are exactly as was highlighted before: age of the patient, tumor mutational burden. All these things help us have a better understanding of what the biology actually is in front of us. So if it's a younger patient with a higher burden of disease, I'll always be more suspicious of Lynch syndrome or MSI high disease. So for example, if I just have an MMR testing result, I'm going to have a lower threshold to reach out to my pathologist and say, well, maybe we should do the PCR testing, maybe we should do NGS testing, sort of look at this sort of more carefully, this case. Whereas if it's an older patient and sort of a TMB low, then I'm more reassured that it's probably an MSS case. So lots of considerations there to consider. Every case is individual, so I like to have as much data as possible.
No, thank you so much. And I think all of you at some point touched upon the collaboration piece. I think to round up the discussion, we would love to hear an example from each one of you, maybe on best practices in terms of collaboration between oncologists, pathologists, and probably the MDT team in general. Dr. Pappas, do you want to start?
Certainly, happy to start. Yeah, so there was one interesting case that was presented at our tumor board, and one of my colleague medical oncologists was sort of driving this case. So this is a case of a patient with metastatic colorectal cancer that came to clinic from an outside institution, had MMR testing that was deficient at the outside institution for loss of MLH1 and PMS2, was started on immune checkpoint blockade inhibitor therapy as standard of care. After 3 months, the patient had progression. So they did both a biopsy and a ctDNA testing. The ctDNA testing preceded the biopsy. ctDNA testing showed MSS disease with a BRAF V600E mutation, but sort of multiple other mutations. Tumor mutational burden was around 20. So with the MSS status, there was a concern that maybe we're not sort of capturing the full case here. So when it did the biopsy, actually the biopsy confirmed on IHC DMMR status. So ultimately, there was multidisciplinary discussion between pathologists and the medical oncology team and geneticists. And ultimately, what was felt was that this was a case of true DMMR loss, but it didn't really behave as a DMMR disease. So it didn't really have this MLH1 hypermethylated phenotype. It was probably a later sort of event that was acquired somatically, and potentially there was mosaicism. So really the clinical phenotype and the response to immune checkpoint blockade inhibitor therapy went along with that explanation. So the patient was started in chemotherapy and then sort of ultimately BRAF-directed therapy, and they're doing well on that. But I think that illustrates the importance of sort of thinking carefully about each case in a context-dependent manner and working closely as a team.
Thank you so much. And that also speaks to the fact that the pathologist learning about the clinical history of a patient would also help, because as you mentioned, there was like onset of new mutation and the status changed for a patient. So that's really a place of potentially retesting, rebiopsying. Moving on to Dr. Schiller, do you want to share an example as well?
Yes. So first, before I dive off into that, I just want to make sure we're talking about the complexities of the testing, but by and large, most cases are going to be routine. So I want to instill and I want everyone to feel very confident in your skills, but certainly when you identify an edge case, please be ready to make sure that because I saw everything, all of the options were checked on what is done with discordant results, and it's exactly what I would expect. There's a variety of different things that are done to manage that. But if at the end of the day, you still feel like maybe there's still more to learn about the patient, to be very diligent about that. So that's working amongst the multidisciplinary team in the laboratory setting, but carrying it across with our clinical colleagues. One thing I'd like to highlight is, what do we do when we're in dire straits, we don't have much tissue left? So sometimes, we may not even hardly have 50 tumor cells for reasonable interpretation for what would represent a large treatment decision. And so there have been cases, and they're uncommon, where I will just render it QNS on the front end, quantity not sufficient, because I don't feel like it's representative enough to make sure that to impact the patient's ultimate treatment decision. So when that happens, I called my colleague right away, phone a friend, hey, just want you to know, yes, I did have tumor, but I don't think I have enough tumor to render a result that's going to actually be reasonable to drive the next step for that patient's treatment consideration. If at some point the patient has another piece of tissue that comes in, let's reconsider it. Or if you've run liquid or whatever else we need to do to get an answer, I just don't want to put data out there that might be confusing. And, even beyond that, what if the patient then transfers to a different center and now we have this result that doesn't maybe necessarily fully reflect their disease? So that would be one example, and I have done that when I need to.
Fantastic. Thank you so much, Dr. Schiller. It's interesting when you are testing, you are thinking about the patient not only in the immediate terms, but also the implications of the results moving forward, because a lot of these actionable biomarkers are being identified during diagnosis. So the results are actually following them, as you mentioned. That's a great point. Moving to Dr. Novak.
Yeah, thank you. So I think it's important to point out that we've spent a lot of time talking about discordance, multiple testing options, and kind of getting to the right answer. Sometimes you do all of that and things still don't make sense. And I can think of multiple examples where we've had that happen in our lab. And really your first go-to at that point should be reach out to the oncologist, reach out to the rest of the team, see if they have ideas. And that has been very helpful for us in our GI molecular tumor boards at the Dana-Farber to discuss unusual cases. And we've had multiple scenarios where actually looking at these unusual cases really teaches you something new about the biology of patients. And one of those was a Lynch syndrome patient, known Lynch syndrome, ran in the family, diagnosed with 2 new synchronous colon cancers, one of which was MMR proficient. And when those results went back, the oncologist thought this is not possible. You guys have made a mistake. We ultimately sequenced both tumors and showed that it was just simply a sporadic colon cancer in a patient with Lynch syndrome that also happened to have a second colon cancer associated with their germline alteration. That ended up being a case report. We had another example of a patient with metastatic disease, primary and reportedly MMR deficient, primary resistance to immunotherapy. And in that patient, there ended up being MMR deficiency in the MET, and then heterogeneity, significant heterogeneity in the primary tumor. Also another case report, and cases that I think then inform your thinking and your approach when you encounter that situation in the future. So it's not just about getting it right for the individual patient that you're working on now, but also extrapolating from the unusual constellations of results that we sometimes see to inform better practice in the future.
No, thank you so much. And all in all, I think it's what we hear is the binary dialogue or even multi-pronged dialogue, including the MDT, a multidisciplinary team at institutions, but certainly between the pathologist and oncologist is critical, and keeping a low threshold, I guess, to reach out to each other. No, thank you so much. I believe we have a few minutes, so if there are any questions in the room, please feel free to step up to the mic that is in the middle of the room. For the questions, we will be hanging in there for a few minutes after the session too. If you want to walk up to us, please go ahead.
Thank you. What is your experience with cytology specimens?
So the question was, what is your experience with cytology samples?
Well, we know that the IHCs do not work as well if it's been fixed in ethanol. So that would be a situation in which you would need to try to find, they're gentler on the DNA. So you could still do the PCR and use that as your benchmark to see if it's stable or unstable. If it's unstable, you'd kind of have to try to get another piece of tissue in some way or fashion, because I just don't think I could reliably report out that result on the IHC. Dr. Nowak?
Yeah, I think the other point, that I would just emphasize is internal positive controls can sometimes be harder on cytology specimens. That would be one of my biggest concerns. But I would also echo the point that while the alcohol-based fixatives are not necessarily the best for protein preservation, that's the best possible way you can preserve DNA. We do MSI by PCR occasionally and NGS frequently off of cytology specimens. They often work really quite nicely. So that is a real option for those sorts of specimens.
Thank you. Are there any more questions in the room? If not, I would like to thank our exceptional panelists for their valuable insights and to our audience for your engagement throughout the panel discussion. And also, I believe the discussion has highlighted the importance of collaboration, the best practices in MSI-H and MMR testing. And I would encourage for us to all continue to working together and really shape the future of precision oncology. So really appreciate everybody's role in healthcare industry, and hope everybody enjoys the rest of the conference. Thank you.
Thank you.
Thank you.
Thank you.